Healthcare, presented by Shivaugn, Simon, Natali, Triana, Grizelle, and Jose. So, to what extent is healthcare a right? Dr. Hildegard Peplau from the State University of New Jersey says that a right is a social invention, an idea that arises from among the people, an expectation or demand formulated as a claim, which then attains further power through custom or law. In other words, society determines what a right is and what it is not. If we take it back to the beginning of the semester, a society with libertarian views might oppose the government's involvement in providing free or low-cost health care, and they would probably find alternative ways to get health care to the poor. A liberalist society, on the other hand, would welcome individual rights and utilitarianistic or Rawlsian approaches to health care. That is to say, utilitarian libertarians would agree with the path that benefits the greatest amount of people, but that does not necessarily mean that there won't be any least well off, and Rawlsian libertarians would see healthcare reform as just as long as it benefits the least well off first. So as this illustrates, the right to healthcare can be different depending on the society and its definition of what a right is. Take, for example, the comparison between Swedish society and American society. In Sweden, the society has established that healthcare is a social right that its citizens should have access to. In the United States, healthcare is seen as a commodity where only those that can afford it are able to access it. So why don't all societies have the same definition of rights? That has to do with the societal values that we apply. Norman Daniels, a political philosopher at the Harvard School of Public Health, agrees that legal entitlements most people believe should reflect what society is morally obliged to provide by way of medical services. Some have argued that without the access to healthcare, this puts citizens into a bind that does not allow them to access other things. For example, the Bill of Rights gives citizens the unalienable rights to life, liberty, and the pursuit of happiness. However, without access to healthcare, authors like Dr. Peplau agree that those rights are limited. For example, a sick individual can't successfully access a full-time job, or an ideal job for that matter, in order to pursue their happiness, so they must either stop working to focus on their health, or work anywhere that gives them the flexibility to be sick. Now, although the United States has shown the small steps it has taken to move towards better access to health care with the passing of the Affordable Care Act, some may argue that access to insurance is not the same as access to care. However, American society is starting to realize that even with some regulations in place, the United States is not quite to the finish line in terms of the social benefits that access to health care for all of its citizens would entail. Dr. Peplau agrees that the right to healthcare is also a recent development that derives from a rapidly growing social awareness of a degree or kind of inequality in our society. The public is noticing that those who are affluent and know how to locate available resources get healthcare of the highest quality, while the have-nots and the uninformed get little care, no care, or low-quality care.
Before answering the question of what do political economists have to say about healthcare, it's important to reiterate what is meant by political economy. As Riddell, Shackelford, Stamos, and Schneider write, and I quote, "Political economy is more concerned with the relationships of the economic system and its institutions to the rest of society and social development. It is sensitive to the influence of non-economic factors such as political and social institutions, morality, and ideology in determining economic events. It thus has a much broader focus than economics." End quote. In surveying the literature, it becomes very clear that the vast majority of political economists are not satisfied with the status quo of the healthcare system in the United States. Many political economists acknowledge that the United States lags behind other developed nations in the area of healthcare in a very, very significant manner. As Sasha Bromsky writes, and I quote, "Having posted huge increases in life expectancy in the first two-thirds of the 20th century, the United States rested on its laurels. While other countries extended health care to all citizens and provided decent antenatal care to all women regardless of income, America, in the latter years of the 20th and 21st century, witnessed an epidemic of uninsurance, with tens of millions of Americans having no access to routine medical care. End quote. So as Sandy, Bodenheimer, Paulson, and Starfield, and Abramsky, amongst many others, point out, the United States' current healthcare system can be made better in a lot of ways. It has a lot of room to grow. Political economists also acknowledge that the current healthcare system really serves to promulgate inequality within the United States, as well as reinforce the vicious cycle of poverty. The real word here is over commodification, which is a term that will come up over and over and over again as one surveys the literature regarding healthcare in the United States. Many political economists argue that healthcare and access to healthcare should be seen as a public good rather than a private good. Many political economists argue that healthcare shares all the same characteristics as do public goods. A lot of them will compare it to something such as police services, something that everybody utilizes, but that should at the same time should not be deprived from an individual because they're not able to afford it. Political economists also point to the inability of the free market to produce the services of healthcare at a affordable cost in an efficient manner. They point to that as another facet of their argument that healthcare is in fact a public good. Political economists also note that issues of health impact every facet of a citizen's life. Health concerns affect a child's ability to go to school. Health concerns affect a mother's ability to provide for her children. They use this as another argument to their claim that access to health care should not be commodified.
Our current health insurance and healthcare system is not sustainable. Americans receive healthcare coverage through either public or private arrangements. Our existing healthcare system faces many long-term financial sustainability issues due to our existing government programs, such as Medicare, Medicaid, and our state's children's health insurance program. These financial restraints lead to the rates that make it difficult for providers to cover the cost of care. Other significant challenges is the insufficient access to specialty care, the insufficient number of providers participating in the health exchange, and as a result, it leads to further illness, which leads to more expensive inpatient treatment.
Eligibility and outreach are other policy considerations that we have to address when speaking about healthcare. Are illegal immigrants or foreigners going to have access to the right to healthcare, or is it just going to be citizens? And the other issue is regarding quality. What type of quality are poor individuals going to receive, or illegal immigrants or foreigners, or is it going to be different than the wealthier individuals, or is it going to be universal? And then the other issue that is presented is outreach, and how are we going to fund these programs to inform the public and to educate them regarding enrollment, the scope of coverage, and other areas that they might need help with. So we have to address both of these issues in order for individuals to participate in our healthcare.
Coordination and navigation are important aspects of a healthcare system. However, the United States often fails to meet the needs of patients during transitions. The chronically ill and the elderly receive poor transitions of care, and there is also poor communication during these transitions. As a result, these transitions only lead to more confusion about the patient's condition, which also delays the diagnosis. This fragmented healthcare system lacks uniformity and leads to a patient dissatisfaction with the United States healthcare system. Patients that are chronically ill can see up to 16 physicians in 1 year, and policymakers need to consider the quality of care and the patient's safety when considering adequate healthcare coverage.
Financing and provider incentives are other important policy considerations that we have to address, because in this country we don't all agree that healthcare should be a right. Some consider it a privilege, so we have to find ways to finance the program if we want to consider it a right. And we could do this through member fees, co-pays, employer contributions, individual or corporate donors, federal, state, or county sources such as taxes, or we could provide subsidies or any other means that we find fit. And the other important aspect is we have to find ways to create incentives for providers so they could lower their costs or provide other services that are going to help the general public. Adopting a view of a right to health care as opposed to seeing it as a privilege will yield many positive externalities. The first thing is that the individual will be healthier in general, and this will lead to social benefits because more individuals will be able to visit the doctor, and in general more people in the population will be healthier. Also, because these individuals are going to be able to visit the doctor, they're going to be able to have preventative measures such as vaccines, and they're going to be able to spot their health issues early enough to prevent major health concerns that could lead to death. And this in general will lead to a wealthier and better economy because more individuals are going to be able to contribute to the community and to the country as a whole. There are other positive externalities that could arise from an adoption of a right to health care, but these are just some of the few benefits that we could encounter.
There are negative externalities to healthcare reform, and about 30 million individuals will remain uninsured and will continue to be uninsured for the next few years. 1/3 of uninsured individuals are undocumented residents. 2/3 are individuals that have incomes too high to qualify for a tax credit, however don't make enough to afford full price premiums. There are a number of people that have high medical needs but are unable to afford the co-payments and deductibles that are part of their insurance plans. A large number of low-income workers that are working for large companies are offered coverage but are unable to afford their rates. Their family members are offered coverage as well, but they are offered at even higher rates. There is also the issue of Medicaid. States were given the option to expand their Medicaid age limit. However, only 23 states made the expansion. There is also the issue of reaching out to people that have a mental illness, have a language barrier and cannot communicate with a counselor. There is difficulty reaching out to people that live in very rural areas and are unable to sign up and enroll for healthcare coverage. The affordability of healthcare costs is a big challenge for many policymakers. Policymakers need to consider that there are about 30 million people who will remain uninsured and will not have adequate health coverage. Policymakers cannot simply assume that everyone that doesn't qualify for a subsidy is able to afford health coverage.
When it comes to determining a just way to pay for health care for those who are too poor to afford it, we must first define what just is. According to the Oxford Dictionary, just is based on or behaving according to what is morally right and fair. As a nation, we have come to regard health care as something of a moral right. If people are too poor to pay for health care and have insufficient economic resources to pay for health care, we as a society have an obligation to ensure that these individuals receive health care so that they may have a fair advantage. With that being said, we have a shared responsibility as a society to pay for the health care of those who cannot afford it.
In order to fund healthcare for the poor, we can develop equitable contributions by utilizing public funding through taxes where everyone pays into the system and government subsidies are provided. This will allow those that live impoverished lives to continue contributing to society and living their lives fully so they can continue to obtain their constitutional rights and continue to live a life with liberty and pursue happiness. However, if funding is not available, a reduction in life quality will influence personal, family, and community wellness. It also reduces an individual's ability to contribute to the economy and ultimate well-being of the nation. It is unjust for people in poverty to be denied care and as a result not be able to live their lives fully and utilize their rights as citizens. Good health is a social good and benefits not only the individuals but all members of society. It is in their best interest and in the best interest of our nation to keep all members healthy. Having health care can generate these positive externalities to all members of society, while lack of health insurance translates into poor health outcomes. To ensure that people live decent lives, they need to be provided with the proper care and basic services regardless of wealth.
While data supports the findings that a high proportion of the American population is unable to attain health care, what is meant by the word access remains unclear, even to policymakers, as there exists no definitive definition as different geographical locations, as well as other dynamics, determine what society deems as equitable access. There are two methods of describing access to health care. First, vertical access is unequal access to unequal needs. The more equitable approach is horizontal access, which is equal access by equal needs. Horizontal access does not discriminate between people who are already ill while respecting acceptable healthcare differences for those with equal needs. A 1993 definition is the timely use of personal health services to achieve the best health outcomes. There are several components to accessing and measuring healthcare. The four main components of equal access to healthcare as described by the national program Healthy People 2020 in affiliation with Stanislaus County's Community Health Improvement Plan are coverage, services, timeliness, and workforce. Improving access to healthcare in the Central Valley is important, especially due to the fact that a number of working poor individuals cannot afford healthcare, while they make too much to qualify for assistance. Fortunately, the Affordable Health Care Act, Obamacare, has allowed many of these people to receive services. The Central Valley has an exceedingly high patient-to-physician ratio. This results in long waits just to be seen, even with insurance. The quality of care drops when doctors are serving an excess number of patients. In the short run, public administrators can help to increase access to health care in a variety of ways. First, multilingual healthcare enrollment fairs are important to empower the community. Events that provide information regarding available healthcare opportunities allows individuals access to programs they may have otherwise not have known existed. Creating an alliance of business and nonprofit members who support making healthcare accessible to all is important. Buy-in with the community from all corners is important as well. In addition, promotion of businesses who create full-time jobs and provide healthcare programs for their employees ought to be recognized as doing such. Over the long run, larger accessibility goals are possible. When planning future facilities, administrators can promote accessibility as a key feature in location, to what population, and in what means of transportation. Due to scarcity, incentives to draw and keep physicians ought to be implemented in conjunction with overseeing that local healthcare providers are meeting the public needs. Streamlining similar programs and services to work together to meet common goals would increase efficiency. The continued collection and analyzation of data for best practices, as well as the continuation of the 2020 Frameworks Plan, will help keep a focus on accessibility and needs. A public campaign to raise awareness to the benefits to having, as well as the drawbacks to not having access to health care, would be beneficial to inform the voting public so they are knowledgeable before measures come around. Clearly, there is much one in public service can do in efforts to raise accessibility of health care to all.
Discussion questions. Question 1. Some argue that the Affordable Care Act does not guarantee a right to health care. Why do you think this is? Question 2. What are some additional positive or negative externalities you can think of that were not mentioned regarding healthcare as a right? Question 3. Can you identify any negative implications, morally or economically, of publicly funding healthcare? Question 4. What barriers do you foresee public administrators having in efforts to expand and improve access to healthcare for all?